Welcome, everyone. My name is Jennifer Chung-Van-Zini here at the USC Suzanne Dworak-Peck School of Social Work and the Department of Nursing. Thank you so much for joining us today at this very special and timely webinar presented by the Department of Nursing here at USC. This webinar is entitled The Health Equity in the Time of COVID, Nurses Providing Primary Healthcare to All. And it's incorporating the social determinants of health in training and practice of family nurse practitioners. We are so grateful to all of our nurse professionals out there as we're experiencing another surge of COVID-19, which has, it's been a long year, and I know many of you are out on the front lines, and so I just want to say thank you to all of you for being on the battlefield as we all face these difficult times. So in light of that, we want to go ahead and talk about some of the issues that have come up during coronavirus pandemic and how the nursing profession has really stepped in and the research and the realizations and all the things that really are putting a pressure on our healthcare. So please listen in, and if you do have questions, we will have time at the end of today's webinar to answer some of your questions. Please use the chat box to interact with one another and the Q&A feature to enter in some questions that you have for our speakers today. And without further ado, I want to go ahead and introduce our speakers. Our first speaker is Dr. Sharon O'Neill. She is an associate professor at the Department of Nursing here at USC, Suzanne Dworak-Peck School of Social Work. She's also an attorney admitted to the Maryland Bar and holds advanced education certification as a family, pediatric, and psychiatric mental health nurse practitioner. She came to USC in 2015 from the Johns Hopkins University and developed the current FNP program, which launched in fall of 2016. Her legal career focused on healthcare regulatory law, corporate transaction, medical malpractice, and products liability. She spent over 13 years as a part-time in-house legal counsel to the Kennedy Krieger Institute in Baltimore. And then our next speaker is Janet Hildebrand. She is a clinical assistant professor at the Department of Nursing at USC. As a clinician, Janet works in a federally qualified health center here in Santa Ana, California, which focuses on population health and eliminating health disparities in vulnerable communities. Her research studies focus on providing comprehensive healthcare and decreasing complications to adult Latinos with type 2 diabetes. And lastly, Tracy Kirkland joins us. She's an adult and pediatric nurse practitioner at the Memorial Hermann Medical Group in Houston, Texas. She earned her Doctor of Nursing Practice from Texas Christian University and received both her Postmaster Pediatric and Adult Nurse Practitioner certificates from Johns Hopkins University. She earned her Master of Science in Nursing from Virginia Commonwealth University and her BSN from Hampton University. Tracy has over 20 years of experience as an adult and pediatric nurse practitioner and more than 25 years of experience as a registered nurse in a variety of clinical settings. An experienced nurse educator, Tracy previously worked as an adult health nurse practitioner, pediatric nurse practitioner, and research coordinator at Johns Hopkins University. Her clinical interest is in prediabetes screenings and screening for diabetes in the workplace. She is also co-PI of several research studies examining hydration. Thank you so much to all of our faculty members joining us today. And we are truly appreciative of this time. And with that, I'm going to hand it over to Dr. Sharon O'Neill to go ahead and start the presentation.
Okay, thank you so much, Jennifer. Welcome, everybody. We feel that this is a very important topic. It's timely, and we're happy to be here today. I think Amanda's going to put the slides up. Okay, so as we said, this is talk is going to be about health equity during COVID and what the role of nursing is. Both nurses on the front line, we'll have some discussion about that, but we'll also have discussion about primary care, which is basically where most patients are coming into healthcare at this point. They're being evaluated in primary care practices. We've listed the objectives, which we believe that will be covered by this talk. I won't read them to you, but I think we will definitely touch each of these issues. I thought since most people don't realize that USC actually has a Department of Nursing, I wanted to make sure that you were aware that we're actually founded in November 1st of 2015, and within a 4-month time period, we got our curriculum through the university and through WASC, which is the Western Association of College of Nursing, with accreditation in 2016. We subsequently got accredited by the Collegiate Colleges of Nursing Education in 2020, and then by the California Board of Nursing in 2019. We currently have 224 students registered. 7 of those students are former military. 1 is actually active duty. 38.4% of our students report being a first-generation person in their family to attend college. Our approach is we teach online with the students coming to campus twice during the semester. Our online lecture sessions are basically a flipped classroom. Students do work outside the classroom for half the allotted time per week. If it's a 3-credit class, it's about an hour and 15 minutes. And then they come to class for an hour and 15 minutes. And we basically apply what they've learned in the asynchronous in Zoom sessions. We also do on-campus intensives, which occur twice during the program, and these are 2 days. Now, due to COVID, we've had to move the on-campus intensives to a virtual experience. So from spring of 2020 through spring of 21, we're doing a virtual experience, and we will actually talk about that a little bit later. Hopefully, we'll be back on campus in the end of the summer. The curriculum has multiple threads, but 2 threads which we think are important to this talk are social determinants of health and health policy. So these topics are threaded throughout the coursework the students take. Next slide, please. Okay, social determinants of health and COVID. Dr. Tracy Kirkland will now speak.
Good afternoon. Next slide. Great starting point. First of all, I would like to ask you just to do a little bit of guided imagery. If you can close your eyes and think back prior to March, your last trip, your activities that you were engaged in. Open your eyes, and it's March 2020. My last trip was to Los Angeles during our actual on-site intensive. March 2020, we saw a decline in primary care visits. Prior to that time, there was an actual decline in primary care visits. What happened during that time is that our nursing students had a decreased opportunity to work in primary care settings, family practice settings, and pediatric clinics. Fast forward to spring, there was decline in screening and testing in primary care clinics. They were less likely to conduct screenings. And now, winter 2020, we're facing some of the same problems. The screenings that are being conducted for COVID are now occurring basically in our urgent care sites. As we look at the initial steady state, we've had a decrease in primary care providers going into the specialty. This is where our nurse practitioner students can help bridge and close the gap. Next slide. Access. During COVID, we've seen a decrease in accessibility to healthcare. We've seen problems with access to chronic medications for chronic disease management, for diabetes, for hypertension. We've had decrease in transportation systems in terms of shuttling. We've had barriers in terms of caregiving. We've had more families that have been furloughed We've had more families trying to dual task and working and taking care of their children while homeschooling. We've had barriers in terms of individuals who lived in rural areas having access to care. And that was due to technology. Sometimes there's a decreased bandwidth, and not only a decreased access to technology, but in some instances, our older individuals just do not know how to operate technology. Some of the things that have occurred since COVID-19, we've seen an increased use of telemedicine. And telemedicine can take form in the shape of phone calls. We can use virtual in terms of the use of systems like hypnosis. And other times it's just strictly narrative information that we receive and we're triaging. Next slide. As a result, what we've seen increased hospitalizations. We've seen decreased utilization of healthcare services. We've seen a lack and or a gap in the continuity of healthcare. And as a result, it affects many individuals who live in vulnerable communities, ethnic minorities in particular. So, what is social determinants of health? Social determinants of health are the conditions in the environment where people are born, live, learn, work, play, worship. And it affects different ages across the continuum. It affects their ability to access health, their ability to function, and it can affect their overall quality of life, outcomes, and risk. Next slide, please. Here in the Houston area, I serve as a member of a collaborative research team, and we created a survey. And we actually surveyed over 630 some students across 3 campuses. And what we found, we were looking to assess the lack of food insecurity, and we wanted to assess some of the social determinants of health. And what we found is that approximately 15.9% of the students had an increased incidence in food insecurity. And this was touted to be, or most likely or postulated to be, related to the lack of continuity in work. Many of them were furloughed, and or others took on 2 and 3 jobs in order to feed and provide for their families. So what does that mean? As healthcare providers in the era of COVID, we're really learning about the importance of incorporating determinants of health. One of the things most recently shared within our AACN is that determinants of health is really an important outcome to measure. The Centers for Medicare and Medicaid actually included a most recent billing code to assess individuals who are deprived and or are suffering from determinants of health. So for us, as we're matriculating or we're educating our next generation of nurse practitioner students, it's really important to work collaboratively with our partners. Next slide. This is actually an example of a food drive. So maybe about 3 weeks ago in Dallas, there were approximately 10,000 individuals who went through a mobile drive-through for food. Here in St. Louis, we had approximately 5,000 individuals that went through or came through the mobile unit. There were actually 6 weeks of mobile services in which they partnered with Cisco and other community partners to deliver food and other services, other services to families. Little is known about the social support and or need for support during COVID-19. A recent study by Sharma et al. 2020 examined social needs of low-income households. Approximately 10,000 individuals were surveyed and only approximately 1,000 participated. And what we saw in that survey is that approximately there was a 19%, 15 to 19% increase in food insecurity. Next slide. What we also know, and that's available, is the Social Vulnerability Index. The reason in which we have that is to assess different communities during times of pandemics and during natural hurricanes or natural disasters. Why is it important? It is important because COVID-19 has exacerbated the rates of disparities. And what is our response as educators and practitioners? Our response is to transform healthcare. Next slide. Again, this is another picture depicting one of our volunteers distributing food. What we would like to do is ask that our students and our faculty and our participants today think of ways in which we can be service-oriented and help during the times of need. Next slide. I would now like to turn this part of the presentation to Dr. Hildebrand. Thank you.
Thank you. I wanted to start off by talking about poverty. Poverty touches all the domains of social determinants of health. Disparities in healthcare are not a new phenomenon. In 1963, Michael Harrington documented the poor living conditions of the migrant farm workers on the West Coast. He looked at the impoverished families in the farmlands and in the Appalachians, and the plight of the displaced, unskilled working poor on the East Coast. He wrote, quote, "They are without adequate housing and education and medical care," end quote. In 1964, President Lyndon Johnson waged a war on poverty, resulting in numerous programs such as job training, new Medicare health coverage for the elderly, and Medicaid coverage for the poor. Fast track 50 years. In 2013, Sasha Abramsky revisited Harrington's account and found that the conditions are worse for many families. People experienced financial crisis after the stock market collapse in 2008. Both authors refer to this population as invisible or the other America. According to the US Census Bureau, the number of people in poverty are slowly trending downward, but the COVID pandemic moved more families into dire straits. The COVID-19 pandemic did not cause poverty, it supplemented it. Next slide. Shelter in place brought a cascade of crisis to many individuals. As Dr. Kirkland also mentioned, there was a loss of income, job instability, and ultimately a loss of health insurance. People had to choose between buying food, paying rent, or paying for their medications. Many outpatient clinics began to close in order to prevent the spread of COVID infection among their staff. Providing care to patients with chronic disease became more challenging, and it took a backseat to COVID-19. On March 1st, President Trump signed the Corona Preparedness and Response Supplemental Appropriations Act and 1135 waiver that allowed for telehealth visits. Beneficiaries were able to obtain health care without leaving home. Before the pandemic, telehealth services was not covered under Medicare services, at least very limited. Outpatient clinics were able to provide access and receive reimbursement. Large healthcare corporations implemented numerous telehealth products while smaller clinics relied strictly on telephone calls. I work in a community clinic in Santa Ana, California. And we in Santa Ana has the highest COVID incidence rate in Orange County. Our clinic uses FaceTime, WhatsApp, or telephone calls. Many of our patients do not have access to internet services, again, as Dr. Kirkland mentioned, which prevents us from using virtual platforms for office visits. We also have seen an increase in new patients who have lost their insurance and have chronic diseases. Chronic disease encompasses numerous entities: asthma, high blood pressure, obesity, and other multiple diseases. I have a handful of patients who have cancer, and they may be going to the oncologist for their cancer care, but they also come back to me for their follow-up on all their other medical conditions, as well as their preventive health. I want to focus on diabetes, however, because there's a high prevalence in the ethnic populations and those in poverty. Next slide. Diabetes has many moving parts. It's a complex disease because of the multiple health issues. First and foremost, we want to control diabetes. We want to control their blood glucose, but we know that 70% of these patients have high blood pressure, high cholesterol, and if they smoke, that increases their risks. There are currently 34.2 million Americans with diabetes, which translates to roughly 9% of the population. And the scary thing is that we have 88 million US adults with prediabetes. So we want to prevent those folks from shifting into the diagnosis of diabetes. Next slide. Although the incidence of diabetes has been decreasing in the last few years, the prevalence is not falling in the ethnic populations, as you notice on the slide. Diabetes complications such as amputation, kidney disease, and/or heart disease continues to soar. We provide chronic disease management to prevent these complications. During this pandemic, our office provided limited office visits, virtual diabetes group visits, and through federal grants, we offer low-cost medications and lab testing. Prior to the second stay-at-home announcement, which occurred in the last few days, we were seeing well visits such as adult and children physicals. So how does this affect our students? Next slide, please. The faculty responded immediately to prepare students to transition to a new way of health management. We developed a COVID and telehealth training module to prepare students for their clinical rotations. As Dr. O'Neill talked about the on-campus intensives, students really enjoy coming on campus to learn new skills that they will be using in their future as healthcare providers. Through the Department of Nursing and the School of Medicine's combined effort, we transitioned the program into a virtual platform. However, we're looking forward to having the students back on campus again. We continue to focus our nursing education on disease prevention and health promotion. This is our strength as healthcare providers. Additionally, we integrated telehealth education in the curriculum because telemedicine may play an important role in the future of healthcare services. We monitor the outpatient processes in order to keep our students up to date and competitive in the ambulatory setting. And now I'd like to turn it back over to Dr. O'Neill.
I'm sorry, next slide, please. So mental health is a major component in dealing with COVID. Part of the, certain issues are becoming to light, which, as were suggested before, were present, but they've become even more crucial during this time. And when we talk about mental health, we're not just talking about mental health of the patients that we actually care for when we're in clinical settings, but also the mental health of the community, the mental health of providers such as frontline workers, and in particular our students, which I will talk about towards the end of this talk. So there was a study done by the CDC, which actually looked at mental health. And during the late June, 40% of US adults reported struggling with mental health issues or substance abuse issues. The common symptoms were both anxiety and depression, which are considered to be two separate diagnoses under the DSM. Substance abuse, people who had either quit and were in recovery, or people who had initiated substance abuse had increased by 13%. Trauma and stress-related disorder symptoms were appearing, and this is both in adults and children. And then the 11% of the people that were polled actually reported having seriously considered suicide. Stress is a major issue, particularly as we go back into a shutdown in not only this state, but where my family lives in Maryland, they're in the process of going through a shutdown. So when people get shut down, as you will see, and the next slide, please, you'll see that people tend to have more problems. So they tracked people in May, June, and July of this year, and they noted that symptoms that people were complaining about were symptoms of anxiety disorder, depressive disorder, and symptoms of both anxiety and depressive disorder. Now, from a mental health standpoint, often anxiety and depression run together, and it's really critical to understand how they work together, because often people who have depression, as you treat their depression, you raise them out of the depression, they actually may develop more anxiety, and you have to start considering other diagnoses such as bipolar disorder or a comorbid diagnosis. So it's tricky when you can't treat people in a face-to-face situation. So as Medicare made that decision to allow for telehealth visit, multiple organizations have switched to telehealth. Of course, people who don't have access to telehealth have a problem. Telephone conversations currently are permissible under Medicare, but you have to have at least one face-to-face visit with the patient through either telehealth, or they actually have to come into the office and you have to meet them. So the rules still aren't favoring people who live in low-income areas and don't have access or transportation to health. Next slide, please. So social isolation is a major problem. In fact, when people shelter in place, it has more of a major impact than when they do not shelter in place in terms of their mental stability. Some patients or persons will report that there's a minor impact, but when you look at the statistics, at least 47% of the population in a large study reported that sheltering in place did impact them. Particularly you can't maintain your social network. If you live by yourself, you're alone, you're elderly, you have family members that are in nursing homes, you can no longer visit them. You can't even visit your family members when they're in the hospital. It creates a lot of anxiety and depressive symptoms. Not sheltering in place has less of a problem, but by itself, the fact that we're dealing with this long COVID pandemic, at least 37% of the population are feeling the effects of it. Next slide. Okay, so mental health in children is one area that we are beginning to definitely look at. And we think about what is the work of children? Well, the work of children is to go to school and to play. Play, as Piaget always said, play is the work of children. So every state in the union at some point closed their schools. Many schools did not reopen. Many schools remained online, but this disenfranchised students who didn't have an internet access or had a poor internet access, didn't have computer access to home. On the other part of this is that many children depend on schools and other settings to provide meals. So students that are receiving both federally funded breakfast and lunch were no longer getting those meals. So kids were actually going to bed hungry. I actually saw a news report where parents were reporting that they were putting kids to bed earlier so they wouldn't feel their hunger pains. The exacerbation of mental health problems in children is rising. I think with all of us in psychiatry, there's a rule that everyone has some piece of a psychiatric diagnosis. We all have either we get anxious at times, we get depressed at times, but most of us can manage it. That's why we don't need services. But we can be put in a situation where those feelings are triggered, and people need support both at the primary care level, but also at the psychiatric mental health level. Next slide. So what is the effect of COVID on children? Well, children are losing their milestones. They're not doing the typical rites of passage. They're feeling isolated. They can't participate in athletic activities or musical activities. They feel it deeply. A recent study in the New England Journal of Medicine demonstrated that adolescents between the ages of 12 and 17 make up the highest proportion of children admitted to the emergency room for mental health problems. And typically these problems include suicide attempts. Next slide. So how do we manage the mental health aspects? Well, I can tell you from listening to my students in my classroom telling me stories. I usually try to have students decompress at the beginning of class because I know the weeks are tough. And when I was preparing this talk, my own daughters asked me, you know, how many times I'd seen a patient die. And I can honestly say that I've probably witnessed less than 5 deaths in my entire career, which is probably about 40 years. I remember each one of those patients. I know exactly where I was when the patient died or was pronounced dead. I mean, I've had patients that have died at home when I didn't see them, but I remember each one of those instances, and I clearly remember a situation when I was in the emergency room at Children's Hospital and I was a triage nurse, and within a 3-hour time period, we had 3 babies that came in that had shaken baby syndrome. 2 died and 1 ended up being compromised for life. It led to an article that was later published in Pediatrics. But I still remember that. I remember the faces, but I can't imagine when my students tell me that they're witnessing up to 10 patients die a week. You know, they can go into work and have 3 patients die. For most of us that are in mental health, we think that there's going to be an emergence of post-traumatic stress syndrome. And I think we're seeing evidence of that now. There have been reports on the news where physicians and other healthcare providers have committed suicide. So we are vulnerable. As a population, we're all vulnerable, but also as healthcare providers on the front line. I think the long-term impacts will be profound, but we need to provide supportive measures and effective measures to deal on multiple levels and across the age span to deal with issues related to mental health and social determinants of health. Next slide. So what are we doing in the Department of Nursing? I think the other 2 professors, Dr. Hildebrand and Dr. Kirkland, mentioned that we really try to support our students through this crisis. And I will tell you, it's been a crisis. We've had students get very sick with this. We've had students that have not been able to go to clinical because they have to care for their sandwich generation. They're caring for their children and they're caring for their parents, or they're afraid to go out into the workforce to work or go to clinic for clinicals because they're afraid of bringing COVID home to their families. They're also becoming the breadwinner for their families. Many families have, as they're multiple generations, they are unemployed. So our students are becoming the breadwinner while they're also going to school. What we're doing is to try to provide support to students, connect them up with resources as needed, either through student health service or other services that are available. We're also providing alternate schedules. So some students are opting not to go to clinical for 2 semesters or a semester, which delays their graduating from the program, but we want to help students through that. We're also looking at what our future projects are going to be for the department because we think there's going to be a pressing need, particularly for primary care providers. We know that persons who get COVID most people do rebound, but we also know there's a subgroup, both in adults and children, that have what's called long haul syndrome, that have prolonged problems that probably will continue through life. We plan to try to develop a doctor of practice and nursing program with a postmaster's track and a bachelor's of science to DNP track. We also are looking at the possibility of creating a psych mental health nurse practitioner program. There's a pressing need for people to provide psychiatric care, and we believe that the nurse practitioner role, particularly for nurse practitioners that are already working as family nurse practitioners, to add that capability to their practice. Since in primary care, I can tell you, I've seen multiple patients with psychiatric problems. That was what prompted me to go back to school and get my certification, because I really didn't know how to manage depression, anxiety, and also other problems that appear, which a psychiatric mental health nurse practitioner can do. And then last, we'd like to create a certificate program for nurse practitioners, such as family nurse practitioners that want to work in acute care. We know there are a number of family nurse practitioners that are currently working in acute care, but they need to be able to work within their scope, and the scope for acute care is definitely an acute care nurse practitioner. So we're happy to answer questions, open up the floor for questions, and thank you for listening to our talk today.
Great, thank you so much. I definitely appreciate all of the great information that you all shared. With all of you here, I mean, as Dr. O'Neill mentioned, many of our students here in the MSN program are actively working on the front lines, and you know, having to balance family life, both, you know, young children for some and also elderly. What are some of the ways, you know, Dr. O'Neill, you said that during class you kind of give a moment for the students to just decompress and to share. What are some comments you've been hearing from the nurses who are on the front lines right now? And this is to any one of you.
Well, I can tell you that what I'm hearing is that students are, in particular, are carrying a heavy load. They have to work. They come home from work, and before they even touch their kids, they have to, or their family members, they have to run and take a shower, throw all their clothes in the wash. They're dealing with the fact that they have become the sole breadwinner. In some cases, students have talked about getting another job in order to keep the family together, because it becomes stressful. So they're opting, if they were full-time, to go to part-time. If they're part-time, to take a leave of absence. I think the thing that is most upsetting to them is that there doesn't seem to be a unified message on how we're supposed to deal with COVID. Wearing masks really does make a difference. I must hear that every class. And I teach a policy course, and students are allowed to bring in different policy articles from 15 of the leading journals on policy, such as New England Journal of Medicine, Health Affairs, and they're constantly bringing in articles about COVID, all aspects of COVID, which relates to what we're talking about, but it's also a way for them to decompress, to deal with other issues. I'm sure Dr. Kirkland and Dr. Hildebrand probably have comments about students' experiences.
Yes, thank you for having us. This has been really good and very timely. But I would like to say that students are faced with mandatory overtime, which is impacting their ability to provide continuity and consistency in doing their work and managing family as well. And additionally, as Dr. O'Neill may have mentioned, we have students that are being diagnosed with COVID. So that in and of itself brings about a different ramification of problems. And as she mentioned and alluded to earlier, this is just the diagnosis. The next step is post-COVID syndrome. We don't know the long-lasting effects. So that's some of the things that I would like to share.
I think one more other aspect that came up here in Southern California, not only were we facing COVID, but we faced fires. And so upon the problem that you're trying to distance yourself, you're trying to do everything. I had one student who was in the verge of tears because she had to pack everything up. She had a newborn and she didn't know what to do. She didn't know what to do. And I told her, just take care of yourself first. Don't worry about this. Take care of yourself first, because, and they need to have that reassurance that they can do that. You know, they have to have that reassurance. And I think that's what we try to provide them. And I try to tell the students, you know, if there's anything going on, please let me know, because then, you know, I mean, their health, as well as their mental health and their family comes first. So that's what also has occurred in my classes.
And that's a good point, Dr. Hildebrand. Additionally, for natural disasters, if you're in Houston and Louisiana, Florida, on the coast, we have hurricanes. So we've had several of those within the last few months amid COVID as well. So that in and of itself brought additional problems. We had individuals from Louisiana who came over to Texas for healthcare. So it goes back to our initial conversation around accessibility. And these individuals would come in for suturing, for laceration repair. They go back to Louisiana and then come back for us to remove the suture. So accessibility and health concerns amid other natural disasters as well.
You definitely, our nurses are experiencing hardships on all. It's like 360. It's in every direction. We do have a couple questions from the audience, and one of the questions that came in was, have there been any studies regarding the efficacy of telehealth medicine? Good question.
You know, I can tell you that telehealth medicine has been around for a long time. It's been around for a long time. And because we've never had to use it as primary care, we haven't really used it. But as a practicing nurse practitioner, it has saved a lot of my families, a lot of my patients. If nothing else, I put them on FaceTime, show me what's going on, because at least it helps me to provide some semblance of care to them. There has been articles written on telehealth. So it's not new. It's not a new thing, but it's certainly used much more today and accepted much more today.
Yeah, I think the biggest issue with telehealth was that most insurance companies and Medicare and in Medicaid in some states would not pay for telehealth visits because they required a face-to-face requirement with you and the patient. And as a result, that's why it was not really to the surface where most people understood it. But once President Trump signed the law which allowed, or the executive order which allowed us to use telehealth, there's been a dramatic rise. I mean, we've had students that did almost their entire semester in telehealth. And when I was finishing up my psych mental health nurse practitioner program, we did mental health, and my preceptors were really concerned about a number of their patients because they weren't going to have face-to-face visit with them. But it turned out our patients were actually doing better than patients that were coming. We had a lot of people coming in that need to be evaluated because they were stressed, because either they had been stable in the past and now their symptoms were emerging. But our patients that were being followed regularly took to telehealth with no problem. We didn't have a lot of crisis with patients that had already been seen and transitioned to telehealth. So I think it's here to stay. I don't think it's going to go away magically. I think that there's actually movement afoot with Medicare to make it permanent. So I think that's going to be the modality.
I think that's exciting. Definitely when technology advances, and the benefit of is that it's going to help many people, especially when you think of rural areas where there's access is very, very difficult. So it's great to see movement in that. There's another question here about how can health plans and other payers better support providers and patients with social determinants of health equity issues from your point of view? Is there a model health plan you'd like to share as an example?
Actually, that's a great question. And I was on in our conference call earlier today, and there are several different models. And I think because of COVID, there's been an increase interest in social determinants of health and research. So stay tuned. I think with regards to food access, I mean, food insecurity, you have to, it's three-pronged. You think about accessibility, you think about the food supply chain, and then the distribution to food within communities. And what we're seeing is that because vulnerable individuals are, especially in the African American or Black community, we already are suffering. We have higher incidence of obesity, higher incidence of diabetes, and higher incidence of hypertension. So social determinants of health, again, isn't anything new. I think that now, because amid COVID, we're seeing more and more strategies and more attention and more research and resources being dedicated. So yes, there are different models. I think healthcare providers or models or payers are probably being aligned or are thinking about innovative ways in which they can support. One of the things that I'm recommending within our healthcare system is to use the food insecurity tool to screen, to do a better job with screening. Dr. O'Neill mentioned the concern with children and food insecurity and going to bed hungry and having hunger pain. We, as a pediatric nurse practitioner, we need to align better and do more screening and better screenings in order to identify these individuals. We have tools that are valid and they're specific. So I think working collaboratively with our payers and with organizations and having a DNP program or a PhD program, we can get these things done.
Great. We have some social work partners who are listening in today, and we've got some great questions about, you know, it appears that the USC School of Social Work graduates and alums could be of service to our to the Department of Nursing. Who, you know, how could we partner? How could social workers and the nursing professionals, how could that you know, collaboration occur during this time?
Well, our students actually take 2 courses in the School of Social Work. You know, we're not just, we didn't just land in a School of Social Work, we became part of the School of Social Work. So we collaborate regularly with different members. And I know I was on Curriculum Council. I mean, we do other activities. So our students actually take one of the first courses in the social work program, and then they take an elective. So they are intimately involved in that. Now, we eventually develop a psych mental health nurse practitioner program. That is definitely an avenue where students would be able to interact, and social workers could really help, particularly when it comes to therapy and teaching students how to do cognitive behavioral therapy and other therapy modalities. A lot of our social work students learn. So if people are interested in other opportunities, well, I'm definitely interested in hearing from them, because I really think that that's the beauty of us being in a school of social work. It isn't something that happened before, but it definitely works with, there's a lot of bright minds, and anybody that has any interest, please, you know, contact us.
And Jennifer, that's a really good question, just to piggyback. As an old public health nurse, and going back to the previous question, an innovative model with nurse practitioners and social work to address some of the social determinants of health in the community, food insecurity, transportation, accessibility, creating virtual telehealth clinics. I think there's potential, great potential. The question and the concern is always what our director is here, funding.
Yes, I mean, we've, the next question is going to talk about the vaccine. And I know when we met, we talked about how one of, yesterday was the first day, the first, group of people got the vaccine in the UK. And so super excited to see that happen. But in preparation for that, you know, a lot of communities, a lot of healthcare professionals have been out in the communities ahead of time, setting up pop-up like flu shots and creating this relationship. And there's very much this collaboration with social services and being able to reach out with social workers and in the community so that access and credibility of healthcare, can go into the community. So, once the question is, once the vaccine is available, will USC offer the vaccine to students as mandatory vaccination, or what will be the vaccination primary prevention approach be? Where are we in that in terms of preparing for the vaccine for especially healthcare professionals?
Well, I think actually vaccines are initiated at the state level. State departments of public health manage that. And I can tell you that all the 50 states have been working on this whole issue for at least 9 months about how they're going to roll out vaccines. Of course, there is some discussion that first line workers would be receive the vaccine first, but there's also the need to also make sure that it's equally distributed among different people, such as persons that are immunocompromised or people who are living in long-term care facilities who are probably more vulnerable. I do know that one of the reasons why there was a spread of COVID in long-term care facilities, and this was actually in the New England Journal of Medicine, was because they found out a lot of these workers work at multiple places. So people were actually, because they were trying to provide for their family, they were working 2 and 3 jobs at different long-term care facilities, and they were literally bringing the virus with them, and that's kind of how it got spread. So in terms of making the flu the shot mandatory, I think that is something that possibly could come down the road, but right at this point, I don't think that decision would probably come from Dr. Van Orman, who's the head of student health services, and also discussion with schools that provide clinical care, with them. It could be similar to the hepatitis B vaccine, which we require all of our students. And I know the medical school and school of dentistry require them to have students to be vaccinated with that. So yet to be seen.
Great. Well, I think that's it for our questions, but I definitely thank you so much for your time today and sharing some of your thoughts and your research and just the personal stories that you all have gone through, and the comments from your students as well. And as Tracy and all of you mentioned, supporting our nursing students is crucial. We do have an endowed scholarship fund here, started by Barbara Jury, who is still very much alive. She's in her 90s right now, and she started this fund in 2016 to support our nursing students. And if you'd like to support this important scholarship, please contact me, Jennifer Chung-Banzini. My email is there. And as many of you may already know, nursing has a long history here at USC. USC first started training nurses back in 1945, and Barbara Jury was part of that in partnership with the California Hospital. And so ever since then, we have nearly 2,000 of you who are USC nursing alums, and many of you have joined us today. Thank you so much for the work that you do and being on the front lines. And as Dr. O'Neill mentioned, many of you have shared with me, if just people would think of their community and others, wear masks and be smart. I think we hopefully will see the light at the end of this very, very long tunnel. Thank you again. We appreciate all that you do. Please join us next year as we continue with these opportunities to engage with some of our phenomenal faculty members like Dr. Hildebrand, Dr. Kirkland, and Dr. O'Neill, and the work that they're doing. Please stay safe, everyone. Happy holidays, and we appreciate all of you. Fight on.